And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of MedEClasses 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases, in which a lot of interactive discussion. And with his wit, with his knowledge, and with his inputs, sir, please come up to the stage. Dr. Yuthika, who has already talked a lot about PCOS and hyperandrogenism. Dr. Vikrant Singh. Dr. Vikrant is a young pediatric endocrinologist from Lucknow. He did training under Dr. Raghupati and now is running his own clinic, Kartikeya Endo Kids Hospital, and Dr. Chetan from CPED Rajkot. So, and I'm joined by Dr. Vibha, who will be posting those questions. So we'll focus on three topics basically: hyperandrogenism, oligomenorrhea, and Turner syndrome. A lot of hyperandrogenism has been covered, so it will be like a revision using cases in that scenario. So hyperandrogenism, we all know we should consider if there is hirsutism, acne. Hirsutism is Ferriman-Gallwey score more than 15 or more than 8 to 15 if you have a worry in that scenario. Virilization, very important. If you have hyperandrogenism, always look for clitoromegaly, voice change, muscularity. That is a dangerous sign. That means that the patient has some tumor cause of that in that scenario. Alopecia, hidradenitis suppurativa, these are the other cutaneous markers of the scenario. Remember, when we say hirsutism, we should distinguish them from vellus hairs, which are normal, soft lanugo hairs, as compared to hirsutism, where you will have androgen-dependent hairs, which are longer, coarser, blacker, curly hairs. You should also distinguish from hypertrichosis. This is from diazoxide toxicity, but other conditions can cause that. And look at specifically in a androgen dependent area. So you should use Ferriman-Gallwey score to rate that. There is a whole in our application also. You just have to select the site and you will get the exact FGS coming out of it from their regards. So if your Ferriman-Gallwey score is less than 8, that is mild hirsutism, don't evaluate in an adolescent. If it's more than 15, even if your testosterone is normal, this is significant. There is a clinical hyperandrogenism. Between 8 to 15, you can look at testosterone level, get a morning testosterone sample. If testosterone is above 55, this is significant. Below 55, unlikely. Now, whether we do a free testosterone, which is a more sensitive assay, I would say it is not very, very clinically relevant. But if you think there is hyperandrogenism and your total testo is normal, you can do a free testosterone, but that's adding to the cost in that regards. Once you know this is hyperandrogenism, the next question is it coming from the ovaries or is it coming from the adrenals? So if you have a high DHEAS, you are most likely dealing with the adrenal pathology, and this will suppress to DEXA. So DEXA suppression is a good marker to identify adrenal etiology, and we had a wonderful case which Sayan presented yesterday as to how steroids suppress the whole process, that is a FAH, functional adrenal hyperandrogenism. Most of us don't use generic response, but that is more of an experimental test in ovarian cause in that regard. Now, when to do a 17 OHP? If your 17 OHP is pretty high, more than 1000 nanogram per DL, you have to start considering non-classical CH. 170 to 1000, you should do a synaptin test. Less than 170 is normal. Remember, 17 OHP should be done in the morning and in the proliferative phase. If you do it post-ovulation, your levels will be falsely high. And suppose you have an amenorrheic girl and suddenly she ovulated in that cycle. So in that situation, falsely, your progesterone will go up and your 17 OHP should go up. So in that scenario, if you are doing an amenorrheic girl, do progesterone and 17 OHP, and we'll have a case to discuss that as well in that regards. So day 2 to 10 of periods, high with ovulation. If you want to confirm an ovulation, progesterone less than 175 is what is recommended. Just to summarize, if you have hyperandrogenism, the key question is if there is no features, don't work out. Otherwise, mild hirsutism is very common. If there are features of hyperandrogenism, are there virilizing features like clitoromegaly, voice change, testosterone more than 150? Yes, this is tumor. Go for adrenal, ovarian imaging. If it's not there, work up basic causes, thyroid, prolactin, maybe cortisol. That is also important. DHEAS more than 700, like our case, which we saw yesterday. Adrenal imaging becomes important. Less than 700, 17 OHP, and then you go for PCOS. So this is the way to go forward. We'll start with the first case, Dr. Vibha.
Thank you, sir. Good morning, everyone. So, a 14-year girl came with a complaint of increased facial hair growth. She had a first period 1 year ago, and she had a complaint that she is having period every 2 months. And on examination, we found that the Ferriman-Gallwey score was 6. And on USG, it was showing there is a polycystic ovarian appearance, and she was diagnosed as PCOD. So I would like to ask, ma'am, sir, is it right to label it as PCOD at this age and with this clinical complaints?
No, I don't think so. We should be labeling this girl. So within a year of menarche, as it is, you have irregular periods because of the hypothalamic pituitary axis being immature. They have chronic anovulatory cycle as a physiological. And her hirsutism is also very mild. So feminine gland is 4 of 6. So I would definitely not want to evaluate her. I would not have done an ultrasound because ultrasound definitely you get that label. It's very difficult to diagnose a polycystic ovary and differentiate it from the multicystic ovary. And as it is, any chronic anovulatory state will lead to a polycystic ovarian appearance. So definitely we should not do evaluation unless it is significant hyperactivity or there is menorrhagia or there is two years post.
So the key message is basically no role of PCO appearance in adolescence. Don't go for ultrasound unless you're looking for virilization. That is different. Then go for CT. FGS less than 8, forget about it. That's normal pretty much in that scenario. Avoid workup within 2 years. Just what Dr. Yutika said.
Thank you, ma'am. Now, another 14-year-old girl came with the same complaint of increased facial hair growth, and menarche happened 1 year ago, and she also had the complaint of having periods every 2 monthly, but she had noticed some body changes like change in voice, increase in muscle mass, and increase in facial hair growth, and increase in growth over pubic hair, and she was also labeled as PCOD. So I would like to ask Shubhra sir, how should we approach these types of cases?
Firstly, as Dr. Anurag is very eloquently enunciated, an FGS of more than 50 is red alert. And I think that's the most important message. Second thing is muscularity. We recall yesterday's pocket Hercules, the 2-year, 9-month-old was muscular. And that's why I called him Hercules. So muscularity means there is an element of high levels of androgens. So this requires investigation and not to be blown away by the PCOD thing. And just to actually reaffirm what Dr. Yutika said is nowadays, especially among gynecologists, it's rampant to do a USG, see those little cysts and say PCOD. And the mothers say, oh, मेरे को भी PCOD है, बच्ची को भी है, ये तो एकदम inherited है. So beware of this philosophy. So bottom line is, yes, this requires evaluation, and I think
So
Anurag will take us through the flowchart.
Yeah. So the workup we did was testo 230. So this is huge. This is male level of testosterone. DHEAS was 900. So as I said, 900 is a huge level. And we basically, if we go by this, we found this the same case in a different scenario, a large adrenal. This was a carcinoma basically. So be wary of an adrenal carcinoma in young girls with rapid onset virilization and progression. That would be the key message. DHEAS is a good marker, more than 700. Very, very careful. Sometimes it may be 3-beta HSD rarely, but tumor is the first thing you want to exclude.
I have a question for you. You know, in premature adrenarche, which also has DHEAS in a 300-400 level,
Yeah.
the parents look at that number and they have this, little girl with a little amount of pubic and axillary hair. They want that to be treated.
Yeah.
What are your views on that?
So first thing, if your DHEAS is less than 30, that is isolated pubarchy. 30 to 150 is premature adrenarche. More than 150, definitely more than 200, I will be wary of CH, and very rarely the same adrenal carcinoma. If it's more than 150, 200, we will get at that age, that is very high. We will get an imaging done, we get a 17 OHP done. Now, coming on to the treatment, there is no specific treatment in this, but we know that this is a part of metabolic syndrome. So this is basically SGA, rapid catch-up, metabolic syndrome, precocious puberty. So in this scenario, there is one big study which was done in Brazil, which basically Dr. Ziziger and the group had done, which shows that if you have advanced bone age, you can use metformin as an agent. I have used in a few patients whose bone age was 3-4 years advanced, no breast development, only adenarche, and that seems to be working, but based on 4 or 5, I can't say whether it is there, but this could be something who has a very advanced bone age and DHEAS is 200, 250, lot of hairs. They will be metformin is the only thing which I think of.
Were they obese?
No, they were lean, but their fat was more. So we have got the BIA and DEXA, so we got their fat was 35-40%, but they were not obese. So this is again that Barker's hypothesis playing around in that regard.
And the important determinant is they were LGA.
Yes, they were all SGA. They were all SGA. So SGA with precocious pubarchy is alag, and LGA and obesity with precocious pubarchy, that is more like a milder early puberty. Then SGA is a sinister thing. So next.
Thank you, sir. 15-year-old girl came with a concern of hair all overall the body, and she had normal menstrual cycle. There was hair all over the body. There was no history of increased hair growth. The FGS was 3, and she gave the history that her father has the same hair growth pattern. So I would like to ask sir, how should we counsel these patients? They were very much concerned about the hair, especially the girls. So what counseling should we give?
Yeah, we have to counsel them regarding the difference between vellus hair, hypertrichosis, and hirsutism. We have to tell them the hair has been present all over the body, and there is a familial predisposition to it. As you have told, the father was more likely going to be a hypertrichosis and Fahrenheit score, which is pretty much low. So we can pretty much assure them we are dealing with the innocuous thing like hypertrichosis, which is a familial component, and we need not to worry about it.
I think the major concern mothers have is that this is going to cause some hormonal problems. So this is what Dr. Vikrant excellently said, that this is just a cosmetic local issue. It has nothing to do with hormones. That is the primary thing, the message we give. So this was basically hypertrichosis, nothing to be done. And this is very, very important, Professor Pratap.
One very important message for the delegates is that hirsutism is male pattern hair growth. So it's all the face, the axilla, the lower abdomen, and the chest. Hypertrichosis is hair all over, and that is hereditary. But in the Feynman-Galloway score, if you look at it, there is hair in the back, hair on the legs. So one very important distinction, whenever you look for hirsutism versus hypertrichosis, is do you have hair in the male pattern hair? And I think to start with face, chest, and if a girl has chest hair and has facial hair, that is hirsutism.
Especially around the nipple area. That is the very, very characteristic sign of a pathological cause. So that becomes quite.
And it's a clinical thing, and it's very important that the hypertrichosis, usually the dads are hairy and the daughters inherit, they look like their dads and they're hairy, and the mothers are worried because they have no hair at all. They look very feminine. So you can
Thank you, sir. A 16-year-old girl came to us with a complaint of increased facial hair growth, and she had amenorrhea, no period since 3 months. There was no history of obesity and no history of galactorrhea. On labs, we found that her testosterone was 68 nanogram per dl, and her 17 OHP was 600 nanogram per dl. So I would like to ask Chetan sir, what should we do next? Should we rely on this single report, or we should run some other test?
So in this report, we have testo which is high, that is 68, and we have 17 OHP that is borderline between 170 to 1000, as sir described earlier. So non-classical CAH is out, but we need to confirm it by doing ACTH stimulation test, whether it rises after giving synectin or not. Second, as sir rightly said, even in amenorrheic girls, if there is an ovulation, so progesterone might be high. So again, we should be doing progesterone as well along with the 17 OHP. So So normal ACTH test rules out in a non-classical CAH and progesterone was high. So this is suggestive of ovulation induced high 17 OHP, but testo is high. So this might be a candidate of other causes of ovarian hyperandrogenism, maybe PCO-like picture.
So I think that is a very critical message which Chetan has given, that if you have amenorrheic girl, you don't know whether ovulation has happened in this cycle or not, you do both progesterone, easily available, robust test with 17 OHP to avoid this confusion. So I think the message is 17 OHP should ideally be done in proliferative, but if you have amenorrhea, you don't know which phase you are. So simultaneous progesterone will help you out.
Thank you, sir. A 15-year girl came with a complaint of hirsutism. She had menarche at the age of 13.5 years and she had period at every 3 months. On examination, we found her FGS score was 16 and she had severe acne. On labs, we find her testosterone was 64 nanogram per DL and the USG, they reported PCO appearance. So I would like to ask Dr. Shubhato, what should be our approach? How should we go further in this case?
This could very well fit in with PCOD. Testosterone more than 50, FGS more than 15. There is certainly hyperandrogenism. Now,
so what sort of management would you treat this girl or not? She is within 2 years of her menarche. So often people say wait for 2 years, but this girl is already in hospital. So what will you do? Will you wait for another 6 months to let her become 20 FGS, or you will start treatment? That is the big question.
I think we have to evaluate further. And I think in hirsutism in girls, the current philosophy is PCOD plus proven. And I think the paradigm shift, and that's where the pediatric endocrinologist comes in, or even pediatrician, to take the ball away from the gynecologist and say, maybe let's look at other things.
Yes, 17 OHP was normal, DHEAS was normal. So this looked like a classical functional ovarian hyperandrogenism, as in PCOS. So the question is, how long do we wait? Now the problem is hyperandrogenism begets hyperandrogenism. Your androgen is more, ovary will become virilized and your pituitary will get knocked out. So probably a lot of people say that if you have at risk, so this will be at risk within 2 years. That's what Dr. Yutika talked about. Probably we will be heading at treatment because 6 months here and there is not going to make a huge difference, and she may become worse if you don't treat and then reassess again in 5 years. That is the major thing, that it may be a physiological hyperandrogenism. FGS of 16 is a bit too much for physiological, so better to start, manage this PCOS and see at 5 years what happens post-menarche.
Basically, just as Dr. Yutika would have enunciated, that the treatment of hyperandrogenism, the treatment of PCOD-induced hyperandrogenism, there are two very powerful tools. One is, OCPs, and the other one is anti-androgens. And the OCP is within the, especially the Yasmins and the Dan-35s, which definitely makes a difference. It makes the period regular. But the anti-androgens, which like spironolactone, it has a huge role. And I definitely think it works. So I think the answer to this question, A, will you take organisms? Yes. Number 2, will you look deeper to find the cause? Yes. Number 3, will you treat with these two modalities?
Thank you. So I think very, very clear. So if you have an at-risk PCOS with severe symptoms, you have to definitely consider treatment. In that scenario, that becomes important, but you have to reassess them once they become 5 years post-menarche.
Thank you, sir. A 17-year-old girl came to OPD with a complaint of hirsutism, and she had menarche at 42 years old, and she had a complaint of oligomenorrhea. On examination, we found her FGS was 18, and she had acne. Her BMI was on the higher side, 32. On lab investigation, we found testosterone was 72. And the USG report showed there was a PCO appearance. So I would like to ask ma'am, how should we manage this case with a girl with PCOS with a high BMI?
So this is beyond 2 years of menarche.
Okay. So I'm assuming that all of the tests
All workup is normal.
all workup is normal. Well, definitely at 17 years, with moderate to severe hirsutism, obesity, and irregular periods, she is a definite case for treatment and a very urgent treatment. She's already lost a few years, so I would call this girl as someone who has had a prolonged hyperandrogenism for a significant period of time. So the chances that she will revert back goes down, and the chance that she is a true PCOS is higher, which is that many years post-menopause. So definite treatment is needed in her case and a complete gamut. So you need to do lifestyle for her because she's obese, maybe add metformin, and definitely the estrogen and progesterone pills, and because her perineal caliber is significant, maybe add anti-androgen, from the start as well. The testosterone is significantly high, so we need to really look at whether our drugs are working. So if we follow it up with the testosterone level, so do a complete treatment in this girl because definitely she is one who is going to land up into PCOS later on also. And counseling and all those things are very important because they will require a really long-term treatment. And definitely they need to understand that having regular cycles in this age group is important for them to have regular cycles later on. So chronic and ambulatory scenario has to be stopped.
So she was started on metformin and OCs. What happened at 3 months? Periods were regular, weight was lost, hirsutism was the same. What do you do?
So again, hirsutism, as I said, it takes time because the growing hairs have a phase. So before 6 months, hirsutism changes and clinical changes very difficult to need to keep counseling them that this will work. But definitely because her testosterone was high, and if you have a cranky family, maybe get a test done to show that things are happening. But keep counseling. Otherwise,
And I think one error will often happen is people get total testosterone done. And total testosterone will falsely be high. So they will say, "Pehle to wo 60 tha, ab 100 ho gaya." Because they are giving estrogen, it will be high. So tell them this is useless, get a free testosterone done. So don't get confused. A lot of people get a testosterone and ultrasound also is the same. They will come back after 3 months. So
they get the testosterone done themselves and come back.
It's because the SHBG is.
yes, SHBG increases with the issue. But 6 months later, no improvement in hirsutism, weight gain, cosmetic measures were given. So I think Dr. Yumika said right away that we should have given spironolactone right at the beginning. So if you have severe hirsutism, we should not wait. But in our protocol, we said you can wait for 6 months. So now we will think of spironolactone. Now what happened 9 months later?
9 months later, everything was stable, but she had intermenstrual bleeding, and she was very concerned about it.
So what will be
So
the
what should be the cause of intermenstrual bleeding? And
Usually, if it is because of clothes-related intermenstrual bleeding, it will present earlier. So if it is happening later on, most likely it is adherence issue, and you need to see whether she is missing out on the pills. But definitely, sometimes with a very prolonged use of estrogen progesterone pills, you develop a really thin endometrium. So if it is not working, and if you think it is not evidence issue, you could get a ultrasound done to look at the endometrial thickness. If it is very thin, then you can add estrogen to it to prevent the intermenstrual. But again, it's not a very significant thing. So if somebody has intermenstrual bleeding and she is not on any estrogen progesterone combination, then it is dangerous. It could be endometrial hyperplasia, endometrial polyp. But if somebody is on the pill and intermenstrual bleeding, it is less likely to be any neoplastic things happening. So it is less dangerous, but more irritating.
And on follow-up 1 year later, her hirsutism improved, weight has decreased, and periods become regular. And I would like to ask them, till how many years or how many months should we continue the treatment?
In this particular patient, because we started late, so she was already 17 years, 4th year post-menopause, and she had a significant hyperandrogenism. So she is in that high risk category where she is going to be up to PCOS. But generally, I would want to give her 5 years postmenopausal. For her, she's already 19, still 19 years, stop and see. So another year of treatment.
So key messages are that if you have obesity, give E plus P and metformin. Maybe consider aldactone if it's a very significant hirsutism right at the beginning. Lag phase is there for hirsutism to respond. Continue treatment for 5 years post menarche. That would be the situation.
I have one quick comment. About a decade ago, there was this doctor from Spain, Lebanese, who prescribed for these patients a combo of metformin, and glutamide. And glutamide has liver toxicity, but it's an extremely potent antioxidant. So glutamide, OCP, and 5. This combo, she won the whole world over. But 2 years later, she suddenly disappeared from the scene because they found that glutamide has a lot of liver toxicity. You penetrate their liver enzymes very carefully. And that is much safer, certainly works. So, a decade ago, I used to have more patients on glutamide. And the interesting thing is, I moved away to aldactone.
I think when you give aldactone, always counsel the family that this is a hypertensive drug, because otherwise somebody will say, "उन्होंने आपको BP की दवा दे दी, गलत दवा दे दी." Tell them that this is not being used for that. I had faced a lot of issue with just using aldactone, but at the end nothing happened. But parents were, somebody told that you given BP medication and everything, and monitor electrolytes and blood pressure. These will be
just like metformin.
Yeah.
Diabetes का दवा दे दिया, वो diabetes का दवा दे दिया. क्या कौन से डॉक्टर के पास जा रहे हैं? So you have to counsel them. There's something called insulin levels versus anti, and conversely, what a lot of dermatologists will do fasting and PP insulin levels, and nothing. वो parents का होश उड़ाना है, तो बस वो insulin levels दिखा लो. Those postprandial. And what do? वो पेपर से आप एरोप्लेन बनाओ और फेंको.
I have a small query for Deepika ma'am. Ma'am, what should be our strategy to carry menopausal PCOS sometimes? Just not a part.
That is beyond this. We'll discuss it in the team day.
I just wanted to add for this patient. When I said we continue treatment for another year, aldactone is something that you might want to, because the idea was to correct her hyperandrogenism. Her hirsutism has become better. That is what you can take her. But we want to continue the estrogen and progesterone for a longer duration. So once you correct her chronic anovulation, her further hyperandrogenism is already corrected. So you can get down on your aldactone, but then you can continue with it.
Thank you, ma'am. 16-year-old girl come with a complaint of hirsutism. She had this complaint since 1 year ago, and she complained of irregular menses. And whenever she had periods, there is heavy bleeding. And on labs, we find her testosterone was 90 nanogram per DL, and USG show PCO appearance. So I would like to ask Dr. Vikrant, what is the cause of this heavy menstrual bleeding during her periods, although she is having irregular periods?
And more importantly, how will you manage this? So this is PCOS with menorrhagia.
Yeah. So first of all, I would like to control menorrhagia. I can give progesterone or something we can, and later on we will shift into higher doses of progesterone as ma'am and rightly pointed out.
So I think this is very important, because this, first of all, of course, progesterone has to be given to control, and then 50 micrograms or something like that. Many of them are large girls, big girls. Often the 30 may not be good enough. 30, yeah, so 50 would definitely be recommended. Very important. So if you have menorrhagia, start at high dose estrogen and then go back to the scenario. So high dose estrogen with severe bleeding.
Thank you, sir. A 16-year-old girl come with a complaint of severe hirsutism and her FGS was very high, 28, and she was very concerned about her irregular periods. Her testosterone was 110 and USG reported PCO appearance. So I would like to ask Dr. Chetan, how would you approach this case? How would you manage this case?
So all other causes ruled out. It is PCOS with severe hyperandrogenism. So a special scenario.
So very high American Galvez score along with the testo, which is very high range of the cutoff is more than 55, so it is double. So definitely, as Dr. Yutika pointed out, that we can give longer cycles of continuous 3 months of estrogen followed by one winter reading of progesterone. So that will effectively decrease the testo.
This is a very important way. Now, I want you to understand that if you give for 21 days, 7 days off, only 75% you are treating. But if you give for 2 months, then or 3 months, also this would be a very good way of giving estrogen. Estrogen increases SHBG. That is the primary role, and that is going to help you out on that. So continuous estrogen in somebody who actually has severe hirsutism. So we have discussed about various cases of PCOS, too much bleeding, too much hirsutism. This is 17-year-old girl, not 7.
17-year-old girl came with a complaint of hirsutism which occurred immediately after the menarche, and there was a rapid progression of increase in hair growth, and she also complained of amenorrhea, no periods since 3 to 4 months, and increase in the muscular mass. In there was she noticed voice change also, and her testosterone level was 200 nanogram.
So this girl had onset immediately after menarche, but it was mild. Suddenly, last 6 months, she has exploded and she's having rapid fever. So was there a low-grade tumor and now it has become a high-grade, or what has happened in this scenario?
So I think the dominant message from such a case is investigate till you find nothing. And again, the adrenal is the biggest offender. You can get ovarian neoplasms. You can get germ cell tumors. So before you say everything is okay, you have to do an extensive workup. And one may argue you may have to go up to a PET scan to make sure there is. Now, after you have truly ascertained that everything is okay, then as this USG shows, a thick thecal membrane. So this is hyperthecosis, and this is the diagnosis of exclusion, right? So diagnosis of exclusion, and this is where we need the gynecologist, the endogynecologist to ratify this. So bottom line is be very, very meticulous to make sure that every other possibility is. And of course, as Dr. Anurag has put up there, you have to do all of the above. Now, was this patient amenorrheic?
Yes, for quite some time. So this is what will happen if you don't treat at the right time. So she had problems and everybody was waiting, okay, theek ho jayega, everything will be fine. Within 3 to 4 years, there was a sudden increase which happened, which means now the ovary was becoming, there was a threshold happening, and suddenly ovary became hyperthecotic, and then these changes started happening. So this is a message that early treatment, don't defer treatment if it is needed. Don't treat if it is not needed, but don't wait and watch. If it is needed, don't wait. Otherwise, you will develop this. This is a very, very difficult condition. It looks just like an ovarian tumor and adrenal tumor. And Dr. Hemchand last year we presented in New York, and there was a case on this hair syndrome presenting as hyperthecosis. So these are all very, very complicated cases, very difficult to treat. They will realize some people say remove the ovaries. That is the ultimate measure because nothing seems to work in these cases. So this is something.
And it's bilateral, right?
It's bilateral. So it's like a general ovaries have now gone into an autopilot. So they are continuously producing. So they are like factories of androgen. That's
So
what I
now they've become testes.
They have become testes. So you block them with GnRH analog. You give estrogen as a backup to increase SHBG. You anti-androgens. You give metformin. But nothing works. It's a very.
Where the initial stage
Yes, this is the first.
breast resection.
So this is that most severe one.
So have you actually encountered?
Yes, we have seen.
And what was the outcome of that?
It was very difficult, and we gave the analog, add back this thing, clitoromegaly stopped, and then they were lost to follow because nothing was happening. We said that we might have to remove the ovaries, then they probably went to somewhere else for consultation.
I actually saw a patient with hypertrichosis in a post, what did we say, a 35-year-old, and who was PCOS, married young, had case, and then had chronic endocrinology. She never cared for it because she already had babies, so previously had already a child. And then, 10, 15 years, no period. Eventually, perimenopausal age, 38, 39, went into severe hirsutism, virilization. So we had to remove the ovaries.
This is a
very prolonged chronic inoculation, hyperandrogenic situation begets hyperandrogenism, which leads to hypertrichosis. So that's why I treat them early, and it's very important even when the family is completed for them to have regular periods.
So tell us about this wedge resection because it reminds me of an MBBS. That is what was proposed there.
Yeah.
What is the status?
So when we never had these diagnoses with scanty tests, the patients would have presented very, very late, usually say about 10, 15 years of amenorrhea and chronic anovulation and hyperandrogenism. So usually only those women who are getting picked up with severe clinical hyperandrogenism. You have pictures of those in many lines. It used to be labeled steam miracle syndrome. Because these guys, opened up the brought me and, partially resected the ovaries. And then they took out a lot of theca tissues, which is eventually basically.
So like partial oophorectomy.
Partial oophorectomy, and then their period started. So that's how this syndrome began.
But then it's such a young girl, so this is not unusual to a total hypertrichosis.
But it can happen. So she had 5, So 5 years was already there since menarche, and right at that time she had perimenarchal hyperandrogenism. And
This case,
so 4 years or 5 years after. So it may happen really because some are more sensitive in that. And often they will have a insulin resistance syndrome, severe acanthosis. So like what is labeled as hair and acquired, so that's sort of, yes.
So would you recommend
No. Now we can use GNR because now we've got, looking towards pseudo.
So you knock off
In this
the-
situation, definitely not because you have to preserve fertility. But if that is not working very well, I think there are case reports of, doing laparoscopic myomectomy in these patients.
Like some people talk about adrenalectomy in CAH. Adrenal is doing nothing good, it is causing harm. Same year, ovary is doing nothing good, only causing harm. And another desperate measure, this is the last resort. But the patient went off. Good. We don't
so
know.
one quick, this 2 years adage which you have been enunciating, post menarche, that is because they have anovulation.
Physiological. That is a physical. So most patients with physiological anovulation should resolve by 2 years. That is the concept.
And you have some hirsutism associated with that.
You can have mild hirsutism.
And this case is where it started slowly, then it rapidly accelerated, and it became a huge problem. So, I think, despite this, let's wait and watch the first 2 years, but have a very close monitoring eye, because these patients can certainly take off and cause problems, as was enunciated.
I think wait and watch strategy is only for patients. So if there are some high-risk patients who will, that they are PCOS, because the definition is saying that you have to wait for 2 years. So if you have a patient who has history of overweight, family history, infertility, IVF baby, or maybe premature puberty, obese, those are the patients where and moderate to severe chronic inoculation, you can begin treatment early also. So that spectrum.
Yeah. So actress PCOS, the case we discussed with you, if we treat at that time, don't wait for another 1 year, the patient will not land up here. Otherwise, there will be a problem. So early treatment when needed, no treatment when not needed. That is the key message. I think this will be the last case we will take up before the break.
Thank you, sir. A 15-year-old girl came to OPD with a complaint of scanty periods. Her menarche started at the age of 13 years, and she was having periods every 6 weekly, and for the duration of only 1 day. And she was advised estrogen and progesterone pill.
There was no hirsutism.
And there was no hirsutism. So I would like to ask, ma'am, how should we manage this case?
Firstly, periods every 6 weeks, I would not call it infrequent, because there is a definite recommendation of when you say, and this is based on what actually would be hypoestrogenic for their own actually to happen. So if somebody is having periods every 6 weeks, regular cycles, not heavy, no hits, they don't need any treatment unless they are longer duration. So in the first year, if you say you have less than 4 periods in a year, or less than basically we will in this third post-menarche year, less than 8 weekly cycles. That is what we recommend for hypoestrogen. The treatment is only when there is basically estrogen is needed for more natural, unopposed estrogen will lead to endometrial activation. So you need for people who are having very scanty period. The definition of scanty.
So I think this is a big message. Do not overtreat. This is a physiological phenomena which will improve over time. No need for treatment in this scenario, and this criteria does not fit. So this is often unnecessary pain. This is like delayed puberty in boys. You say wait till 14 years. Same thing is happening here. The girl has started walking, like it's like the toddlers, what UC conference says. They will have khadaenge, they will fall down, and then they will have a stable thing. So they will take 2 years to mature there. And